Hello, everyone. Good morning, good afternoon, and good evening to all of you who have joined in today. I'm Dr. Neeta Radhakrishnan, and it's my pleasure to invite you all to the first of the webinar series on advances in thalassemia care. This webinar series is being done in collaboration with Thalassemia International Federation, Thalassemics India, ICO India, and our center, Postgraduate Institute of Child Health at Noida. It's my pleasure to invite our chairperson for the day, Dr. Androlia Eleftherio, the Executive Director of TIFF, for her opening remarks. Dr. Eleftherio obtained her graduate and postgraduate degrees in biochemistry, microbiology, virology, and business administration from London universities, and she's been awarded a number of scholarships by the Cyprus government, the World Health Organization, and the Fulbright Commission. She has been working from 1990 till 2006 as the head of the Virus Reference Center of the Cyprus Ministry of Health. And through her work with TIP, Dr. Eleftherio has carried out numerous projects of local, national, and regional and international scope, working closely with international experts and thalassemia associations. She's a member of the Cyprus Hemoglobinopathies Forum and acts as a director of Cyprus WHO Collaborating Center of the Cyprus Ministry of Health. Furthermore, she participates in the European Union Committee of Experts in Rare Diseases and has served on the board of directors of European Public Health Alliance and on the advisory board of European School of Transfusion Medicine. I would request you, Dr. Eleftherio, for your opening remarks today.
First of all, thank you very much for giving me this honor and privilege to chair this very important webinar, starting from the first in series, and the theme, Advances in Thalassemia Care. So I can see distinguished speakers and members, and we are very proud as Thalassemia International Federation to work for many years with Indian NGOs headed by Mrs. Julie and Mr. Deepak Chopra, and to work with the scientific and medical community for many years in India. And indeed, we have seen that governments and other relevant stakeholders, including the patient and healthcare professional communities, have been focused for many years on improving policies for the control, the prevention and management of these disorders in a large country like the Indian subcontinent, with huge heterogeneity both in the genotype, phenotype, but also differences in the policies of addressing effectively these genetic hereditary diseases that have multi-organ impact and of course require multidisciplinary approach. India has done significant steps, has promoted policies for the quality care, for the social integration of patients, for improving safety and adequacy of blood, for giving chelation monitoring of development of medical complications. But of course, in a large population, again, there is considerable room for further improvements. One of our first concerns at Thalassemia International Federation, and Mrs. Julie being an eminent board member for many years now, as well as holding the capacity of vice president for many years, knows that one of our main concerns is to be able in a country to provide services that are based on the principle of universal coverage. Both health and social services for a chronic disease need to be based on universal funding, health coverage, health and social coverage. So one of our goals as the Thalassemia International Federation is to support and advocate for universal health coverage-based systems, particularly for our chronic patients, because it's the only way that effective and appropriate care can be provided. We have seen, as I previously said, important improvements in the development of guidelines in India, in the promotion of centers into reference expert centers. We have seen huge contribution of scientists and healthcare professionals across India in the public literature, which is very important. That means that India has also been concerned with research in the area. We look forward now to move forward as the times we are living now, despite the many geopolitical, environmental, climatic, economic, public health crisis, yet we are also living in a period of huge, impressive scientific advances. So while at the same time we strive for ensuring that basic care, optimal care as described in guidelines authored by international experts, is implemented and is adopted for every patient across the country and across the world, I should extend my advocacy. At the same time, we will be also striving for providing and making these innovative drugs, these transformative drugs that have been authorized, and a lot of them are in the process of being authorized, make them accessible to our patients where possible without jeopardizing the standard care. We need our patients to be provided with the standard care as the recommendations of the international experts are, and the national experts in your country, which have provided the recommendations in your national guidelines based on international expertise, but also on national experience. So while providing and striving for those to be implemented for every patient in every state across the country, at the same time, science has provided with those advances that some of them promise to transform the very pathophysiology of the disease, decrease transfusion times, decrease morbidities, increase survival and social integration of our patients. Some of also promise holistic cure, particularly, as we all know, based on the gene-based therapies. So while we strive for ensuring that these become accessible for the patients across the world and in India, we strive for better care and implementation of the standards of care as in the international recommendations. So I welcome this series of webinars. We look forward to the experts expanding on the individual and separate themes according to the program. And I very much congratulate the supporters, Thalassemia India, ECO, and the center of the Thalassemia Center that we look forward to inaugurating as a TIPS collaborating center shortly, the Postgraduate Institute of Child Health in Noida, which serves over 400 children. And I would like to be provided with this opportunity to, in particular, thank and congratulate Dr. Nida Raghbaraja for this leading, for her leading role in the development of this center. So we are excited as TIF about the potential for supporting these webinars, for further collaboration. And last but not least, I pass on our gratefulness and appreciation for all the policies and all the interest that your government is showing throughout the decades. Without government commitment, any other initiative cannot really come to fruition. So congratulating the patient voice, which becomes stronger and stronger, and patient engagement and meaningful involvement is very important in any decision taken. And we have seen India following and adhering, adopting this policy. Congratulate the healthcare professionals, research and academia, but again, the government, which continues to be committed for further improvements. So thank you very much for giving me this honor and opportunity. And I look forward to the webinar's results and conclusions. Thank you.
Thank you, Dr. Eleftheriou, for those inspiring remarks. Now I'd like to invite Mrs. Shobha Tuli. Madam is the Secretary of Thalassemics India and the President of Federation of Indian Thalassemics. Mrs. Tuli is a founding member of Thalassemics India, which was established in 1987 and has been serving in the organization since then. She has been a board member of Thalassemia International Federation since 1994 and has presided over the Federation of Indian Thalassemics since 2000. Over the last 36 to 40 years, she has dedicated herself to the field of hemoglobinopathies, and her work has gotten Thalassemics India the Best Social Organization Award in 1998 from the Ministry of Health, and she was presented the George Englesos Award by TIFF for her exceptional service to thalassemia patients in India. She has significantly contributed for the prevention and control of hemoglobinopathies from the National Health Mission under the Ministry of Health and Family Welfare and continues to be a strong advocate for patients and parents. She has been working on the disability revision guidelines as well, and her work has been acknowledged by the Indian Academy of Pediatrics with a Lifetime Service Award as well. I request you, ma'am, to welcome all delegates on behalf of Thalassemics India and to set the context for this program. Thank you.
Thank you, Neeta, for your kind words. Good evening to all our international guests and pranam. Good evening and happy Ashtami and Navami to all my Indian participants who have joined from India. So on behalf of once again on Thalassemics India, PGICH and ECO, I welcome Dr. Andrula Eleftheriou, Dr. Michael Augustiniotis, Dr. Tulika Seth for joining us today. I also welcome my co-host, Dr. Neeta Radhakrishnan, for taking this initiative of hosting the ECO webinar series. Thank you very much to all of you for your time. You will all agree with me that this topic of epidemiology of thalassemia, global and national perspectives have been discussed a number of times on different forums by the different associations, internationally as well as nationally, on the national platforms as well. We all know the importance of this topic. We are the ones, especially, it is very important for those countries where still the prevention of thalassemia is not taken up by the respective governments on a mission mode. So since we all know that how important is this topic, and so this is another attempt by ECO and by the organizing committee to talk more details and to understand what is the situation in our country in India and what we can learn from the international experts. Apart from this topic, there will be, as Neeta has earlier explained, there's going to be a continuation of this webinar series, which will be held on the 4th Saturday every month from 6 to 7:30 p.m. and which will be participated by the international experts as well as by the national experts, because there is no point if we do not involve both the experts, national as well as international. So we will not be able to come to any conclusions, as well as to share with the participants that what is new, what is happening on the international front, and what we have to learn from them, and what is also happening in our country. So this is sort of a very, I can say that a great learning, teaching experience once again, and on the advocacy experience as well. Dr. Andrula was talking about she talked about the Indian perspective, and I know that Dr. Andrula knows everything about in each country, I can say, but since we are talking about India now, she knows all the details, what is happening in India and where we are, what are the gaps, what are the challenges. But what she mentioned here is she talked about the standard care. So I feel I request and I propose to Dr. Neeta and to Dr. Tulika, and also to the coming speakers that we'll be having in the coming webinars, that we have to, our approach and our focus should be that, well, after we finish this webinar series, we should come up with a paper, a conclusive paper with all the details we are talking about the prevention, we are talking about the numbers, we are talking about the care, we are talking about the cure, we are going to talk about what are the new treatments will be there, but some standard of care, which is very, very important, because this is a very big problem in our country. In one state of the, in our country, we have the best of the facilities that we can offer to our patients, but in the other state, we have where our patients are still struggling to get a unit of packed cells, or to say, not to talk of the safe blood. So I feel, and I propose to the to my to the organizers and to all the experts who will be here joining us later on, that, well, we should, after the end of this series, we should come up a conclusive paper. We should present it to our government in one of the other forums. Maybe, you know, we can think about, after we finish, we can do a physical meeting. We propose them that, well, this is what is there and what we have learned, and this is what we propose to the government and to the ministry. This is very, very important for our patients' perspective. And of course, for the unborn communities, we have still to focus on such webinars and to continue doing all those activities till our government starts with the prevention program on a mission mode. Thank you very much once again for joining us today. And I hope that this webinar series will be productive and fruitful. And thank you very much once again. Over to Dr. Neeta, please.
Thank you, ma'am, for those words. And we always discuss, the voice of the patient and the parent is the loudest in chronic diseases platforms. And really thank you for all the work that you're doing. This program has been organized through logistic support from ECO India. ECO is a telementoring platform which has been working in multiple public health issues globally. So we are joined by Dr. Sandeep Bhalla. He is the Vice President of Projects at ECO India, and he'll speak to us briefly on how ECO has been working in capacity building in thalassemia since the last few years. Over to you, Dr. Bhalla.
Thank you, Dr. Neeta. First of all, it's one of the fortunate day for all of us today that we are going to start a new arena altogether, where we are bringing about the international key opinion leaders also, as well as our Indian key opinion leaders also, for the one cause, that is thalassemia. So respected Dr. Andrula, who is the Executive Director of Thalassemia International Federation, Mrs. Shubhatuli Madam, Secretary Thalassemia India, Dr. Michael from Thalassemia International Federation, as well as Dr. Tulika Seth, Professor, Department of Hematology, and none but not the least, our own senior lead for this particular program, Dr. Neeta Radhakrishnan. Big thank you on behalf of ECO. ECO started this journey in this beta thalassemia arena in 2022. When one of the initiative came over to us, and we rolled that initiative, as Madam was talking about, standard of care is one of the biggest issues. So with the help of the key opinion leaders, under the guidance of Dr. Neeta Radhakrishnan, Postgraduate Institute of Child Health has been taken it up as one of the national hub center, and we have taken it up 3 knowledge centers to disseminate this particular program. And we took up Kolkata Municipal Corporation. We have taken the Madhya Pradesh National Health Mission, Gandhi Medical College, and the third one which we have taken up is the Bombay Municipal Corporation, Dr. Mamta Miglani Center. So with this, we started the dissemination in a very case-based learning mode, because that case-based learning is the ethos of ECO. And ECO is a not-for-profit organization. And when we started that, it was all new. And that time, we have taken Indian Academy of Pediatrics as one, and Pediatric Hematology chapter as one of our academic partner. And all these associations, Thalassemia India, they are all our one of the, you can say, the expansions of our work in the Thalassemia Society, in the Thalassemia India. You can see that. So we trained around 350 medical officers, including some pediatricians, by conducting batch size of 50 from different these 3 centers. And we also started the webinar series for the Indian perspective. But today is a new arena which we have added, where the international speakers as well as the national speakers are joining hands, and they are going to discuss about the global perspective and the Indian perspective about various issues related to thalassemia. So on behalf of ECO India, we would be very grateful and thankful to all of you for giving us this opportunity. On behalf of my leadership, I would say big thank you. So let us have a very fruitful learning experience from each one of you, and our support would continue for holding such type of dissemination so that the knowledge should reach to the last mile. So thank you, stay safe and stay healthy, and have a wonderful learning experience. Thank you.
Thank you, Dr. Bhalla. So now moving on to the academic part, it is our fortune to have two very senior speakers today. The international speaker for today is Dr. Michael Angastinoitius, and Dr. Tulika Seth is our national speaker today. Dr. Michael will be talking to us first. He'll be speaking to us on the global epidemiology of thalassemia. He is a medical advisor for Thalassemia International Federation. Dr. Michael has graduated in medicine from the University of Scotland in 1966 and has obtained his diploma in child health and pediatrics from the Royal College of Physicians of Glasgow. He received his graduate training in pediatrics in Scottish hospitals in Oxford, and he returned to UK for various courses such as thalassemia genetics and hematology oncology. He's been a member of the Thalassemia Control Program from the outset and is a vice president of the Cyprus Society for Spastic Children. He's a chairman of the Medical Records Committee and the Committee for Computerization of Health Service. Dr. Michael is also a special advisor and consultant for the control of hemoglobinopathies in Eastern Mediterranean region. He is a member of the board of directors of the Cyprus Institute of Neurology and Genetics and a WHO expert advisory panel on human genetics. He has a lot of publications in scientific articles in the topic of the topic that we are discussing today, which is hemoglobinopathies and thalassemia in particular. And until retirement, he was the director of the pediatric department of Archbishop Macarius III Hospital and Thalassemia Care Center. And since 2004, he has been employed by TIFF as their medical advisor. It's our honor that you're joining us today. Over to you, Dr. Michael.
Okay. Thank you, Dr. Nita. And good evening to all my fellow pediatricians. I feel very comfortable knowing that pediatricians are my main audience. Let me share my screen. Sorry. Okay. And just to make it clear from the beginning, I'm going to concentrate on the global epidemiology of beta thalassemia. If I went into alpha thalassemia and sickle cell, we would go to the early hours of the morning. So I'm concentrating on beta thalassemia. And you may ask, an organization like the Thalassemia International Federation, whose main objective, as you have heard from Dr. Andrulla and from Mrs. Tooley, is the well-being and the welfare of the patient. What are we doing with epidemiology? Epidemiology is extremely important. It's important because it's the basic ingredient for developing policies, for developing services. And therefore, we need accurate knowledge. What is the size of the problem? What is the burden of thalassemia? Where are the patients? Where shall I plan to develop my services? So it's an important part of knowledge. We need to know the requirements of these patients so that we can achieve their well-being and survival. We need to understand how much money we have to spend. What are their real needs? And if we don't have enough, how do we prioritize? This is a very sensitive subject because who deserves our care more than others? So these are all issues that epidemiology seeks to answer. And of course, we need to be accurate. And accuracy is something that is actually missing, partly because there are no accurate data either on carrier screening or on the number of patients and where they are. So accuracy is actually lacking. And everything I say from now on is going to be a little bit speculative, if you like. Also, we need to remember that epidemiology is a changing issue. It's not static. There are migrations. There are human interferences through prevention, for example, reducing birth incidence. The complications increase the burden of disease in the aging patient. So all of these issues are data which we want to translate into actions. So what I'm really talking about is translational epidemiology. just a brief reminder, what are the basic needs of our patients? What do we need to plan for? Voluntary safe blood, the provision of essential drugs, mainly the chelating agents, free medical treatment with equity of care, the quality of care through expert centers, multidisciplinary teams, good psychosocial support. So these are things we have in mind for the welfare of our patients. All these things need planning, especially monitoring of the patient's progress. So these health services that we want to develop, what do they really need in order to help us achieve our goals? First of all, we need to be able to talk to policymakers and make them understand. Sometimes they say, I don't have the funds to treat the children properly. We have to make them understand that if they don't treat the children properly, they're going to spend more money in the adult patient who has already developed complications. So it's a false economy. We need to give optimum care as soon as we can. That will save money in the end. We need to know, in other words, the whole picture of the country. What country are we dealing with? What is the epidemiology we want to know? First of all, we want to know its health status in general, the life expectancy, the infant mortality rate, how much money is earned, how much money is spent on health. All of these issues are issues which will give us a picture of the country's status. And of course, if I want to go into detail, and I'm certainly not going to read all these things that you see on this slide, but in the TIF, we have developed our own database, and for each country, these are some of the topics that we gather data on. So what I'm really trying to point out is that epidemiology is not a simple task. It's not a simple task because we need political commitment. This has already been said by the previous speakers. We need to understand and give to the politicians a picture of the burden of disease. And I'm going to speak about burden in a minute. We need to make resources available. So a budget has to be made. We need to prioritize the condition and recognize its needs. We need to see whether prevention is going to save resources for our existing patients. We need to recognize the benefit of holistic and individualized patient care. All of these issues mean political commitment, and all of them require community support and advocacy from patient organizations like ours and like Thalassemia India. I want to stop a little bit because in epidemiology, we speak about burden of thalassemia. And very often when we speak of burden, we think of patient numbers. But it's not just patient numbers, is it? Patient numbers, of course, are important. We need to know the age distribution of these patients. The burden of a childhood suffering from thalassemia is not the same as an adult, especially not an adult over the age of 50. We need to know the complication rates in our particular population. Have we reduced the complication rates? Have we allowed an increase in complication rates, which means an increase in expenses and a reduction in the quality of life? What treatment modalities do we need to offer? How much? How much blood? What about productivity? If I've treated my patients well, they've gone to school, that's productivity. If my patients are adults and they're working and paying taxes, that's productivity. Are my services supporting this kind of productivity, or are my services reducing productivity? These are all issues that we must think about. What about social support? If there is no universal health coverage, if there are out-of-pocket expenses, will there be catastrophe in the economy of the family? All parameters have to be costed. We've got to put a figure to them so that we know what investment has to be made. And of course, part of burden is the quality of life. Pain. Pain is very common in adult thalassemia patients, chronic pain. That's burden of disease, just as much as number of patients. So all of these issues have to be considered in our epidemiology and what we understand. Now, behind all this is the economy of the country, but I'm not confining my thinking to simple economic indices. I'm thinking of more complex indices, like the one adopted by WHO called the Human Development Index. And this includes not just economy, life expectancy in a country, and the level of education in terms of years of schooling, etc. And in the slides that are going to follow, red, countries that I put in red, you will see are of the very high HDI level, in other words, very well developed, green, high, and medium and low in black. And of course, the world has been mapped according to its human development. And the darker the color, the more strong is the Human Development Index. So this gives us an idea of what each country is more or less capable of. I'm going to give you some figures, but I don't want to rest too much on figures, but they are important, obviously, in epidemiology. I have divided here the WHO regions, with the exception of America and Africa for various reasons, but mostly the regions where thalassemia is quite prominent. Europe. As you will see, the well-developed countries include, in Europe, are 64%, and no European country is in the medium and low. In contrast to Southeast Asia, where in fact now there is one country with a very high HDI, and the rest, and 67%, are medium and low. But then again, Europe is only hosting about 3% of the global patient population. So I've got 97% that live outside Europe and live possibly in their majority in less than very high HDI or well-to-do countries. So this immediately tells me that thalassemia patients may very well be shortchanged in many countries. How many patients do we have globally? According to this table here, which is based on the TIFF database, I see about 800,000 beta thalassemia patients, both transfusion dependent and non-transfusion dependent. I think this figure is possibly exaggerated by the fact that many, in the literature, China is credited with about 300,000 patients, but in fact, they are much less. I only know, for example, of 15,000 who are under treatment at the moment. So at least we know that there are more than 500, more than 500,000 beta thalassemia patients across the globe. And where do these patients live? Obviously, in certain areas of the world, which we already know about. The Mediterranean part of Europe, which has about 10 thalassemia patients per million of the population. A group of high-density Arab countries where there's about 20 per million thalassemia patients, but most of all, the Indian subcontinent and Southeast Asia. So we are basically what we have is an awful lot of patients that need our attention. Many of them are not receiving the attention they deserve. A little bit about Europe. I don't want to expand too much on the European issue, but again, the fact of the matter is that most patients in Europe live in high, in very well-to-do countries. However, apart from the Mediterranean countries, most of the patients in Europe are rare in the indigenous population, apart from the Mediterranean, and are mostly migrants. And since they are migrants, mostly from the Indian subcontinent, by the way, and now more recently from Africa, these have their own peculiar socioeconomic issues that have to be dealt with, as well as the disease. And one of the issues is, of course, that the doctors and the health services are not necessarily prepared. So not everything is rosy in Europe. In a few countries like Cyprus, France, Greece, Italy, the Mediterranean group, they have long-standing control programs and a long-surviving population. If you look at especially Cyprus, Greece, and Italy, the average age of the patient is nearly 50 years old nowadays. And many of them are professionals. And yet in Northern Europe, there may be patients that are isolated, and the medical services don't have the expertise to deal with them as they should. So just a general picture. The Middle East region of WHO has a huge burden of disease in terms of patient numbers, and yet about 5 countries have got the economic possibility of offering the best optimal care. Do they? Not really. There are about 6 countries in this area where many patients survive. However, again, they cater for only 8.7% of the patients of this region. The majority of patients in this region live in low and medium HDI countries. So again, even though there are rich countries in this region, we have to consider that the majority of patients are not living in these countries. So again, we have a problem in reaching them as far as possible with the best possible services. Worse, this is the region where there are war zones. And you know the tragedy of what's going on in the Gaza Strip at the moment, and in some of the other countries listed here. Our patients there, we are well aware, we're trying to keep contact, and they are truly suffering. So again, epidemiology is required in emergencies. We need to know what's going on minute by minute. So I think I've said most of these things, and I should continue with the Southeast Asia region, in which India belongs. This has one of the most populous thalassemia populations. Some of the countries are actually fortunate in their own distress, if you like, for the simple reason that there's a lot of E-beta thalassemia, which has a lot of patients with a milder thalassemia syndrome. However, the needs of patients in the Southeast Asia region are huge. I'm not going to talk very much about India because Dr. Chulika is going to speak, but we have issues that we have to consider in this list of patients. First of all, only one country of this region has actually just been promoted, if you like, to the very high HDI country, and that's Thailand. The rest of the countries are in the medium and low HDI levels. And that's where the majority of 200,000 patients live. So the resources might not be available. Expected births are quite high, and prevention policies in most of these countries, apart from Thailand, are practically non-existent. So we're increasing the burden of disease in many ways. We're increasing it by allowing more and more patients to be born, and we're increasing it because we are not offering optimal care, and we're increasing complications. And the burden of disease is going up instead of down. One phenomenon that it's not clearly seen here, but is that if you look at the number of patients recorded in Indonesia, for example, you will see that it's equal to the number of babies born. We've got about 10,000 patients recorded and about 10,000 patients being born. Now, unless the figures are wrong, this means that where are all these babies going? Are they dying in infancy without a diagnosis? This is something that, this is an epidemiological observation. Whether it's accurate or not, it's an observation that has to be investigated. The same goes for Nepal. Practically the calculation of babies born and the calculation of recorded patients is practically the same. An observation that we have to follow. And yet, government interest is evident, both in India and in Indonesia and in the Maldives and in Thailand. How is investment going? How supportive? This is something that we need to see from the results. We need to follow outcomes to see if this government support is actually helping. It must be helping, I'm sure. However, we need to remember Bangladesh, Myanmar, Nepal, Timor-Leste, no government support or national program exists. If you're a thalassemia, if you're a family with a thalassemia patient in Bangladesh, you have to pay for everything. There's hardly any support from anywhere. So the possibility of long survival is minimal, and the tragedy of the family is maximum. I've put some figures here about thalassemia in India. India is very complicated. First of all, because of the geographical distribution, which is quite varied. the tribal distribution, which is also quite varied. And of course, reaching patients is not easy. There are distances, there are expenses that are not seen. I'm leaving everything to be discussed by Dr. Julie Gasser. And of course, India shares with many countries a deficit in the blood supply, and therefore many patients receive less blood than they should. Very quickly, the West Pacific, an area with an awful lot of patients, many of them in the intermediate clinical spectrum. However, quite a few rich countries here. Quite a few countries have given emphasis to thalassemia, and good services are available. With the exception of Cambodia, Laos, Papua, and the Philippines. Vietnam is doing quite well recently. So things are changing in Vietnam, but there are countries, again, which are not offering very much to their patients. I don't think I should discuss very much. In China, it's really south of the Yangtze River where most of the thalassemia patients are, in the 10 provinces south of the river. In some of these provinces, both prevention and treatment, like Guangxi and Guangdong, are actually improved and of a very high level. In other provinces, not so. Let me finish by summarizing my thoughts. What is the idea of translational epidemiology? It's a tool. It's a tool for service development. We need to know the economic resources of each country. We need to know its HGI ranking, its socioeconomic development. We need to know whether political support and prioritization of thalassemia is actually forthcoming. If not, are we raising awareness? Is there a community voice? Is there advocacy? This is something that's extremely important because politicians and public health people are not always aware of thalassemia and its burden. We need to accurately quantify the burden. In other words, we need surveys, we need national registries, databases. We need a kind of micro-mapping of each country so that we can locate our attention and our services. We need to know accurately the global population. The importance of universal health coverage. We're talking about lifelong disorders. I'm speaking the obvious now, but it's catastrophic for families. It's totally destroying the infrastructure of the family if they don't have the full support of the state in what they buy, in what they spend. Clinical expertise. Now, it does exist in reference centers. In many countries, you see 1 or 2 reference centers with excellent services, but in the periphery, nothing. So unless we plan through epidemiological knowledge where our services are, encourage networking and collaboration between centers so that all patients receive equitable treatment, then that's how to go forward. We need to reduce affected births if possible through prevention programs. And we need to monitor closely what our patients do. What about their morbidity, the complications, the mortality, what is the age distribution of our patients. I want to thank you for your attention and remind you all that we have a choice. This group of patients were Cypriots of the 1940s. Whether this is what we want for our patients or whether this is what I want for our patients. This photograph is for an Italian lady. It's the mother who has thalassemia major. It's the mother who is transfusion dependent. But you can see from her face that, and from the fact that she's a mother, you can see that this is really what we want. This is what we want to achieve. Thank you.
Thank you, Dr. Michael, for that discussion on the global epidemiology, region-wise epidemiological breakup, and how, you can hear me, right? Dr. Michael, for that region-wise breakup of the epidemiology of thalassemia, and how, as the community, we should come together to address. It's the issues that we need to address are similar for every country, but we can definitely take cues from what has worked in other countries and implement it in our country. So that's a big a discussion for another day, definitely, for how to implement these practices and how to convince our health ministries to implement cares and bring in standards of care which are uniform for the country. So as you
Yes.
mentioned in your talk, like we always wondered when we keep saying that India has around 10 to 12,000 new patients every year, but once we take a final count, as in there's no national registry, but still when we even look at centers which are managing, we hardly see more than 25,000 patients, not more than that. So that's the big question as to where are these children going. So it's probably because they're not diagnosed, or they're probably diagnosed but they die early in their childhood because of lack of proper transfusions, or probably they don't even get registered to a tertiary care center which is giving data. Thank you. And so we'll take questions at the end of the second talk. For the second talk, I would request Dr. Tulika Seth. Madam is a national expert for you today, and Madam needs no introduction in this gathering. Dr. Tulika Seth is a professor of hematology at the All India Institute of Medical Sciences in New Delhi and leads the technical working group for hemophilia and hemoglobinopathies at the center. And furthermore, she is a member of the Executive Councils of Hemophilia Federation of India, and she is one of the founding trustees of GAP Health, which is Genomics and Public Health, which is an NGO set up for increasing genetic literacy among public. She completed her postgraduate education and training in the USA at the University of California, San Francisco in 1997, and she was the Chief Fellow of the Children's Hospital of Orange County Pediatrics at California. She is a diplomate of the American Board of Pediatrics and returned to India, where she joined the Institute of Rotary Cancer Hospital at AIIMS, New Delhi in 1998. Subsequently, she joined as faculty in the Department of Hematology in 2005, where she's been there and since then, and she's pioneered evidence-based low-cost interventions and therapies for hematology and hemato-oncology patients. She has also acquired a postgraduate diploma in bioethics from the ICMR Fogarty International Center in USA in 2012, and she serves on the bioethics board at her hospital and other organizations. She is a passionate medical teacher, and her students are now heading many organizations in India and abroad. Over to you, ma'am, for your discussion on the national epidemiology trends in thalassemia.
Thank you so much. Can I request your team to allow me to share? It's saying host has disabled sharing.
Manisha,
So,
could you
ma'am,
check?
yeah, so Dr. Michael, I request you to stop sharing your screen so that Dr. Tulika can share. Thank you so much.
So my job has been made really easy because Dr. Michael gave an absolutely fantastic talk. I hope I'm audible and my screen is visible.
Yes, ma'am.
Okay, fantastic. So just a little bit of statistics about India. So our current population as of today is about 1.45 billion. and that's about 17 or almost 18% of the total world population. In comparison, America has a population of about 300 million, and that's about just 4% of the world's population. So we have a huge population, and even rare diseases are not rare in our country. So, understanding the burden of healthcare that the hemoglobinopathies presents to the patient, the family, and to society, the government has actually done a very amazing and wonderful thing, because even though we don't have a lot of data, most of the data we have is from screening programs in small pockets of the country. We don't have population-based data, but the Indian Council of Medical Research has done a fantastic job of mapping hemoglobinopathies all over the country in different pockets and regions. And that data has been extrapolated and used mostly. So these are small samples which have been extrapolated to our large population. But in 2016, in spite of not having population-based data, the government went ahead and allowed us to start the programs for thalassemia prevention management that we have today. And in those programs, many good things were done, like registration of blood banks, like ensuring free blood, that is, no either payment or no replacement donors were required for thalassemia patients. And in many states, free, all of this has already
Okay.
been done, and the government rolled that out in spite of not having data. But as part of the program, they rolled out a plan for registries so that they would be able to collect the data as the programs were being rolled out. And a lot of data has already been collected and collated. So that has gone to all the way down to the district level, so that we can use that information for procurement of blood, for building blood banks and other things. In India, we have all the spectrum of hemoglobinopathies. We have sickle cell disease, HPE, alpha thalassemia, as well as many rare disorders like HPD, lipor. And we are seeing many, many patients with compound heterozygote states. So beta thalassemia major has probably been the most widely discussed and widely understood, but all the hemoglobinopathies are present in our country. And this is why it's really important for us to have good public health programs to address these issues and to make sure that even primary care doctors are aware of this. So, as I said, the Indian Council of Medical Research has been doing some fantastic work on hemoglobinopathies, including thalassemia and sickle. And they have documented a lot of regional variations across the country. Most of their research has been in high pocket areas where there's a high carrier rate. And in certain populations, like in certain tribes and marginalized communities, they have been able to do population screening in villages and smaller regions. But as I said, for the whole country, we don't have data. The incidence and prevalence data is lacking, one, because and also there are a lot of variations in some of the surveys that have been conducted, because they've used different methodologies. They've, some have done population screening, some have done only targeted screening, some have only identified patients. And a lot of these rates reflect the carrier rates in different states, the genetic profiles, the family practices, social and other economic factors, where because of stigma, a lot of times family members are not willing to come forward for screening. So we know that the data available already shows that there is a very high burden of disease of both beta thalassemia and sickle in India. Um, the data is probably underreported. There are probably many, many more patients who are not diagnosed. Um, the average prevalence rate of carrier rate in India is 3.4%, which translates to about 35 to 45 million carriers. And that's in our multi-ethnic and culturally and linguistically diverse population. And that includes many tribals. And this was from an article in 2011. And as you know, our population has increased more. There are certain communities where the carrier rate is even higher, up to 4%. So the thalassemia is a disorder which affects almost every Indian population. We have many states, and there are certain states and communities such as the Sindhis, Gujaratis, Bengalis, Punjabis, where it's a little bit more common. However, it is said that thalassemia is found in every part of the country, even in the south of India. So, if we think about it, we have the largest population of thalassemia major patients and a very large number of persons with carrier state, and the carrier rates vary from different communities. In some communities, extremely high, in others, it's lower, but it's practically there in every community. So, why is it a burden? It's a burden because, okay, this is a repetition, sorry. So state-wise. So now we really need to look into micro mapping, as Dr. Michael had said, and some attempts have been done to do this by screening programs by the government and by collecting data from centers where blood transfusions are given regularly. So we have a e-Rakt Kosh, which is an electronic database of blood banks. And what they found is that in central India, states like Madhya Pradesh, Chhattisgarh, sickle is found in certain districts, but thalassemia was found in all the districts of Madhya Pradesh. In Chhattisgarh, sickle was and thalassemia were both found in all the districts. Jharkhand is a very important state in central India, and sickle and thalassemia was found again in all of the states. So in central India, we see a really high burden of both sickle and thalassemia.
Ma'am,
In the
sorry to
north of our
interrupt.
country, in Punjab,
Tulika ma'am.
Rajasthan, Jammu Kashmir, Himachal Pradesh, Uttarakhand, UP, Delhi, and Haryana, all of these areas were found to have a very high prevalence of thalassemia. So these are areas where sickle is found in only a few districts, but thalassemia is found in every district. In
Tulika
the
ma'am,
west of
sorry to
the
disturb.
country,
Ma'am,
yeah,
there's some issue regarding the audio. If you could speak up loudly, few people are not able to hear properly, ma'am. Sorry to
sure.
interrupt, ma'am.
No problem. Thank you. In the west of our country, we're finding similarly, almost all of the state districts have thalassemia, and some of the districts have sickle. In the east, again, all of the districts have thalassemia in the eastern part of the country. That's including Assam, Bihar, West Bengal, and even in Orissa, there are very high areas of thalassemia. And in the south, which we don't usually think about thalassemia, but there are many districts where thalassemia is very, very common. So in all of the southern states as well. So if we look at this, every state in India has an issue. A recent article in 2023 estimates that India alone contributes to about 25% of the global beta thalassemia burden. And in this article, they did a really good review. This is just one of the tables where they looked at different communities, and they analyzed all the data that was published to, to see where they had the highest carrier rate. And as you can see, there are certain communities where the carrier rate is extremely high. A meta-analysis of all the published data from India was done, and in this uh, they pooled in all the data, and they found a significant amount of heterogeneity, and this was because of different populations and the different carrier rates. But altogether, the carrier rate was about 3.7%, and amongst the tribals, it was up to 4.6%. And this is again a very lovely review article by Dr. Sumedha and Dr. Anita. Now, another thing that makes it very difficult for us to get data in India is that There are 68 beta globin gene mutations that have been identified, and this is work from Dr. Sujata Sinha, who's my colleague. And of these, 10 are a little bit more common, but 68 mutations makes it really difficult. And these also are have different prevalence in different areas. For example, codon 5 is most common in West India. South India, you have other ones that are common. North India, other ones. So it makes it really difficult to do mutation testing in these patients. Another reason why it is sometimes a problem is that we also have delta gene mutations, and they can reduce the hemoglobin A2 level. So if you're doing screening or testing by HPLC, again, that can be an issue. And many of the patients who are our patients reside in rural areas and may not have access to all the testing. And we know that there are very few centers in our country that are currently offering prenatal testing. So, diagnosing patients, making sure these patients get access to preventive or prenatal testing is definitely an issue. And with the variability of patients that we see, using only one test, we can definitely miss, and even molecular testing is definitely not easy. So a lot of things have been done, and I think groups like Mrs. Tuli's Thalassemics India and other excellent NGOs working in thalassemia are very important to continue to raise the awareness in the general population so that there is a public demand for screening. The government is doing screening to some degree, but we need to ensure that at least all pregnant women get screened. We also need to make sure that the screening is done in a good way so that we don't miss any patients, we don't get any false negatives, because in India, as I said, there's many reasons why we may be missing some patients. We need to ensure that the data is linked to some sort of ID, because many patients have had screening done, but they've lost their reports or they've forgotten their reports, and that might be important later on in life. We need to ensure excellent genetic counseling, because if the counseling is not done appropriately, the patient, the family, and the cascade screening doesn't happen because they don't really understand the implications of this. Databases and registries have started, and we're hoping that good geo mapping and micro mapping happens right to the district level so that we can ensure that we know exactly how many patients are present in a district, and who needs to be counseled, where prevention strategies need to be done, and how much medicines and blood transfusion and other things need to be there. The blood transfusion scenario has definitely improved. The government is doing a fantastic job. We have Ayushman Bharat packages. That's a national insurance scheme, packages for free blood transfusions, for free medicines, for free testing. This is a really big step forward. At the moment, the Ayushman beneficiaries don't our country, and but hopefully this is going to continue to improve. The disability bill that Mrs. Tuli and I've been working on, we are also trying to ensure that all the patients who have disabilities, such as the blood disorder disabilities, should also get free insurance, should also get the Ayushman Bharat benefit. We're hoping that that will definitely happen. So yes, a lot of work has been done, but definitely there's a lot more to do. And having data is going to really help us with that, because as Dr. Michael had said, data is really the basis of all the planning that is there. And again, I would like to thank the government that they had faith in us, that they started this program without having too much data. But now it's really important for all of us to collect the data, provide it to the government, so that improvements in the programs can happen. And we're also at a little transition phase. Hopefully, the government will listen to the patients, and there'll be more refinements to the screening programs that are being done, so that we can ensure that all patients have an opportunity to be screened and tested and to get the information about their thalassemia status. So with that, I'd like to end. Thank you.
Thank you very much, ma'am. So we'll wait for questions to come in. By the time yeah, so I think we'll start with the questions in the chat box. I would request both Dr. Michael and Dr. Tulika to give their comments. So so this is, I think, a comment which is there in the program. So are there any legislations in countries like Italy and Greece to prevent the birth of babies with thalassemia? And is carrier screening mandatory? And are two carriers allowed to marry? That's a question which has come from Dr. Namita.
I better answer that one. No, there is no country that I know where patients or where couples are not allowed to marry. They can be counseled, but the decision is theirs. With this must be respected every time. Now, there are countries where religion or legislation don't allow or don't like termination of pregnancy, even in very early pregnancy. In these countries, the push, if you like, is for preventing marriages between heterozygotes. But this may work or may not work. It can only be done by counseling. It's not done by forbidding marriage.
Thank you. So I have a follow-up question on that. So among all the preventive efforts that have done, so when you screen carriers, when you do cascade screening versus screening of school-going children versus screening of college-going children versus screening prior to pregnancy, prior to marriage, and prior to pregnancy or during antenatal period, is there a is there any study that has looked at which is the most effective way of screening for carriers in thalassemia?
Okay, again, I have to speak because of my global. Basically, each society has different characteristics, and each society has to decide for themselves what the best issue is. For example, if you take the Arab world, in the Arab world, consanguinity, cousin marriage, is very common. Now, if you're dealing with that kind of society, you can get good results by family screening. In other words, I find a propositus, either a homozygote or even a heterozygote, and if I examine the whole family, I will get a big crop of carriers that I can actually inform that and let them know that they're in danger. In Cyprus, for example, when we started many, many years ago, the issue was not, people rejected any idea of us interfering with their choice of partner. And they preferred premarital screening, preconceptual screening, and they tended to choose prenatal diagnosis as the way out. But they wanted to marry whoever they wanted to marry, whether they were carriers or not. So this is one cultural versus another culture. So each culture has to make its own decisions.
Thank you. I would request Dr. Tulika Seth to share her experience in an Indian context. Which one do you think is the best way of trying to advocate for prevention?
So the study, the Jai Vigyan study, which was done by Dr. Roshan Kola ma'am from ICMR, they had screened school children, and what they found was that these children were about 14, 15 years old. And when they assessed them a few years later, they found that the majority of them had forgotten their carrier status. So that's one of the reasons why we are advising the government when they're doing screening, if they're doing screening in schools and colleges, to kind of focus on older children, maybe college going or class 11, 12 rather than class 8. For what the easiest thing to do for India is to do the antenatal testing of pregnant mothers, because that is a group where they are definitely going to be coming for some blood tests and some healthcare assessments, and that's also a time that interventions can be offered. To do a population-based screening of even just all the school and college students would be a humongous task, and at the moment, as you all know, health is a state subject. So some of the states are kind of taking it up in a small way and doing it in small districts, but nobody's really taking it up in a big way. So that's why we're proposing the antenatal testing. And as Dr. Michael said, there really isn't any use to telling young people that they shouldn't marry a person, because if you give them a report that they're a carrier, and some of the states, they've actually come out with these cards where they're saying that two carriers should not marry and you should match your card. But what's happening is that because people don't get the message, they get this message that because they are a carrier, they shouldn't get married at all. And so what they do is they simply hide the card and they don't share that information. So it's actually not at all productive. And first of all, it's not the government's responsibility to do that. And just because we don't have enough treatment or other prenatal testing, that doesn't mean that we should tell people or interfere in their reproductive rights. So I think at the moment what the government is doing is the antenatal testing, but we need to make sure that that is universally done, because unfortunately there are women who haven't had their antenatal testing, and that those are the cases that we are finding that are still being born with thalassemia major. So this has to be done in a really, really good way.
Thank you, ma'am. I can see Mrs. Tuli's hand up. Yes, ma'am.
Yeah. First of all, Namita, I'm very happy that you asked this very valid question about legislation, because in the recent past, we have been hearing for many thalassemia NGOs, that we need a legislation from Government of India. So you have heard that no country has got such kind of legislation, and that Dr. Tulika has also said that it, and Dr. Michael has also said, it depends upon the country that what steps they have to follow up, towards the control of thalassemia. I want to make a few comments. Dr. Michael has very rightly, he mentioned in his talk that the average age in Italy is about 50 years, and most of them are professionals. So after I finish my comments, I would like to ask, although I know the answer, but I don't want to comment, I would like to hear it either from Dr. Tulika or from Neeta, that what could be the average age of thalassemia patient in our country. And the secondly is, I feel that, of course, Dr. Tulika has very rightly said that we have tested all that although we are keep on holding the screening camps in the schools and colleges, but of course the best results we can get it by either screening the extended thalassemia families or by proposing the antenatal testing. And whereas we have to now, I feel that our Government of India, and Dr. Tulika and Dr. Neeta and all the doctors who have joined us today from India will agree to this, that Ministry of Health Family Welfare in the last 10 years have taken a number of very productive steps, whether it is towards the management, whether it is initiating the new schemes, whether it is revising our disability certificate, the Thalassemia Bal Seva Yojana running successfully in our country. Nowhere in the world, I have heard about this, such a good scheme to help the patients towards their cure by a corporate under this CSR. I know that still, a number of steps have to be taken by our country, but I want to share with all my fellow people who are here joined us today. The numbers are huge in our country. We don't have to be, that feeling sorry that, well, we are not able to reach to that stage. wherever the European or the USA or the other countries have reached, even in Asian countries. I feel we have come a long, long way. And that has only happened with the help of the governments, with the hospitals, with the help of the doctors, with the help of all the thalassemia NGOs, and of course with the patient advocates. And we will keep on moving. And we have to work together as a team. And I'm very sure that in the coming years, maybe 5 to 10 years, our government will soon, come up with such schemes that we are going to have a universal health coverage for all our patients, and of course to move towards the control of thalassemia. So this is all that I wanted to share with you. Now I would like to, and one comment Dr. Tulika said, Dr. Michael, the problem in our country is that 67% of our people reside in rural regions. So that is a very big challenge, not only for us, for our government of India as well. So Dr. Neeta or Dr. Tulika, I would like to hear from you, what could be the average age of our thalassemia patients as an estimate?
There's the same
I
question
don't
in
have
the
data on the average age, but I do have thalassemia major patients who are in their 40s. I don't have anybody in their 50s as yet, though I do know of patients from other hospitals. So I think the age is gradually increasing over time. We'll have to wait and see if all of our patients reach to their 40s and 50s, but many of my patients are married, many of them have children, many of them are leading very active, productive lives and are professionals. So it's not as bad as it used to be, but definitely we have to continue working.
I
Dr.
agree.
Neeta?
I agree with ma'am. Although I don't take care of those patients, but I do know of patients from groups who are in their late 40s. And I think we have a same question from Dr. Anand Prakash. He's a professor of pediatric hematology at St. John's Children's Hospital. He has a question on, do we have any updates on the life expectancy of beta thalassemia across the world and in India? I think it's a same question for India. I think ma'am has answered. What about the world, Dr. Michael?
It's varied. In what I call the reference countries, Greece, Cyprus, Italy, some parts of the United Kingdom, in London especially, what we have is a population with an average age of almost 50 nowadays. And they are adults. I think Mrs. Chuli was in London and she met George, who's 67 years old and thriving. So, but this is not universal. It must vary. And in India, I expect it will vary. In India, what I expect is that reference centers, big centers like in Delhi, they will have an increasing life expectancy and probably reach their 40s very easily. But again, you have emphasized, and Mrs. Chuli has emphasized, 67% is a rural population. It's not just rural, it's tribal. The education level, the distances, the difficulties of reaching them in prevention. Walking around with an old-fashioned technology like Nestrov or something to do prevention. All of these are issues which are difficult to meet in a huge country like India. So I would congratulate those centers which are doing their best and offering their best to their patients, and hope that the government finds solutions for the rest. And what I'm saying about India goes for the rest of the world as well.
Thank you, Dr. Michael. There's one more question from Dr. Prakash. Are there any regions in India where screening has been successful? I would request Tulika ma'am and Mrs. Tuli to answer.
Gujarat has been doing a fantastic program. They have a program linked with the Red Cross. I think the maximum number of screening that has been done in Gujarat. If I don't know if there's any other states Mrs. Tuli may know.
I think Sankalp Foundation is doing an excellent job in Bangalore. I visited their center just a month back, and they are collecting samples from all over the country. And they have an excellent lab which has been established there by them. Apart from that, the Hyderabad Society, which is a Thalassemia Society of Sickle Cell, and they are also doing a lot of work on thalassemia screening. What we are doing it in Delhi is to, through our center and along with the Rotary and through the MCD, to just to do the antenatal testing. So there are a few on their own with some help from the government, but the NGO is getting the funding from their CSR partners. And some of the states, of course, Anita and Dr. Tulika, some states like Gujarat, you have said, Calcutta, even West Bengal, and even in Punjab, some work is being done. Dr. Neeta can perhaps tell us about that.
Yes, ma'am. It's in different states have started, and I would also like to highlight that recently, so after the capacity building program of ICO started, the Calcutta Municipal Corporation has now made it mandatory for all antenatal women to undergo HPLC. So that's again a very welcome move. It's come late last year, and it will go a long way in reducing births of E beta as well as beta beta in the state of West Bengal. There are a couple of more questions in the chat box. We'll quickly finish it. We have 3 more minutes. So in countries, Dr. Namita asks, in countries like Greece, Italy, or other Western countries, is the national ID linked to thalassemia status?
No.
Okay.
No.
Thank you. And one more question is, okay, it's becoming, so again, Anand, he's a pediatric hemato-oncologist. So he says it's becoming difficult to get adult physicians to take over care of adult thalassemia patients. Are there any strategies for that?
Have a new transition of care policy by the government of India. So if they should look at those policies and follow the guidelines in that. And in fact, Lady Harding, which is in Delhi, they had a absolutely wonderful, excellent pediatric thalassemia unit under the able leadership of Dr. Jagdish Chandra. And now their adult side is also doing a phenomenal job. And Dr. Ritika's there, and they have a wonderfully smooth transition of care now from the pediatric to the adult. So it is definitely possible. The other option is for centers to come up like our center at AIMS, where we see the patients throughout their entire life because we have both adult and pediatric doctors. So the patients come to us and they stay with us forever. So there's 2 options that people can have, and they can see whichever model works best for them. But ultimately, the focus has to be on the patient and to ensure that they get good care all through their life.
Thank you, ma'am. And I think I can't see any more questions, but one final question from my side. So in India, the disability access is for reservations, as in it's for education, basically. Currently, we are not offering job reservations. So I would request Dr. Michael to tell us, enlighten us if if there are reservations for jobs in any other countries for thalassemia major patients or non-transfusion dependent thalassemia patients.
Yep. In fact, I only know about Greece. In Greece, there are laws which help, first of all, the thalassemia patients to enter university more easily. And I think there is a proportion set aside for jobs. But along with other disabled, by the way, not just thalassemia. But in many countries, this does not exist. And in fact, there are thalassemia patients who totally object to the term disability. Mrs. Tully knows George, I mentioned before, he hates to hear the word.
Thank you, sir. And I think one last question, again, advocacy related question in the chat box from Dr. Pranav Mishra. Why is thalassemia blacklisted by most health insurance companies, and what steps should be taken by the NGOs working in this regard? So again, comments from all three of you.
I don't think thalassemia is blacklisted. It is just that most health insurance companies will not insure anybody who has a pre-existing condition. So that goes for any pre-existing condition. If somebody has pre-existing cancer or any other pre-existing condition, then the insurance companies do that. But so that's regarding that statement. And I do know that many of the blood disorder groups are working towards trying to get insurance for patients with thalassemia, sickle, and hemophilia. Maybe Mrs. Tuli can answer more on that.
Yep, Pranav, as far as insurance is concerned, it's not blacklisted. It is only that earlier insurance companies were not that much interested, in looking after the genetic blood disorders like thalassemia. But at present, we are in touch with them, and they are considering, and soon you will be hearing from us through us that what are the next steps and what the decisions are going to be taken by them. So you will hear a good news. I don't know what will be their conditions and all that, on which I cannot comment at this moment.
Thank you. So I think any last comments, Dr. Michael?
No, I'm actually quite happy with what I've been listening to concerning India. I think you're moving forward, and that's always what we want.
Thank you. So with that, I think we come to the end of today's program. It's been a wonderful discussion, and I personally learned a lot from both the talks as well as the questions. Now I'd request Mrs. Suli for the concluding remarks.
Well, first of all, I would like to thank our two speakers, Dr. Michael Augustiniotis and Dr. Tulika Seth, for their excellent deliberations and the excellent presentations. And I always feel that learning never stops. So with today's webinar also, I also came across a few new things which I did not know it earlier. And I'm sure that all the participants, which are I think more than 80 have joined today, for today's our first webinar, they will be also agreeing with me on this. A few things, my last comments on that Dr. Nrula in her earlier remarks said in her earlier speech, said that talked about the universal health coverage, which I strongly feel that should be one of our agendas. And I hope by the end we finish up with this, all the webinar series, we will be talking more about this, that this is the need of our patients. And our focus should be totally on two things: universal health care for all patients, and of course also control of thalassemia, which should include awareness and screening, because without awareness we cannot achieve what we want to do. And then another is the one comment I want to make it on the disability, which Dr. Michael has said. He gave the example of Greece, and I want to share with my fellow participants here who are joining from India that in Greece they have a very good pension scheme also, and which is, I know that how much they pay to the thalassemics. So the thalassemia patients have the opportunity to work as well as they get the pension from the government. That's the only country which is running and having a very good, successful RPWD, the privileges that we are expecting from them. Another problem which has been discussed, another issue, is the transition of the patients. I feel that this is a very common issue which I have heard on various international forums also. So it is not only in India, but in other countries as well. So together we have to think about that how we can move towards it, what are the steps that have to be taken up in our country, and how. And of course, the one example has been given about Dr. Jagdish Chandra Center there, and they have beautifully, the patients are looked after, the ones they shifted from the ward to the adulthood ward, So we have to, and that has happened due to the advocacy. And Anubha was taking transfusion there, and she was the one who was very vocal about this, that, well, the transition has to take place. And that is how that new transfusion center has been created there. So with these words, I would like to thank once again all our speakers and all the participants who have joined, and they are all doctors. And I hope that whatever has been discussed here and will be taken forward by them to their patients, to their parents, and to the other doctors. And with this, I would like to thank once again my co-host and the ECO for giving us an opportunity for holding this webinar. I wish you success, and I wish that all the remaining webinar series will be held up in these pleasant manner, and we will all continue to learn more and more from our international as well as from our national speakers. Thank you very much once again.
Thank you.
Good.
Namaste.
Bye.
Thank you, everyone. With this, I'm closing this session.
Thank you. Thank you.
Thank you.